hematoma. So basically, MMA embolization is a minimally invasive procedure that involves blocking the damaged part of the middle meningeal artery. And the chronic subdural hematoma is the type of bleeding that occurs between the brain and the thin layer of tissue that surrounds it, called the dura mater. So these are the presenting symptoms of chronic subdural hematoma. And it can occur in older adults, especially those with a history of head trauma and those who take medications that increase the risk of bleeding. So these are the predisposing factors in the occurrence of chronic subdural hematoma. And the dominant theory revolves around the rupture of bridging veins traversing from the brain to draining dural sinuses within the subdural space. But there are several characteristics of chronic subdural hematoma that argue for a more complex process as listed. So the hemorrhage leads to the proliferation of dural border cells. Influx of inflammatory cells to the injured dural border cells layer promotes proliferation of the cells into forming new membranes that are fragile and leads to rehemorrhage. So the notion of subdural hematoma resulting from repetitive indolent inner layer hemorrhage naturally suggests embolization as the treatment strategy. These are the treatment options listed for chronic subdural hematoma, which depends on the clinical status of the patient. And these are some of the indications that may warrant middle meningeal artery embolization. In fact, it was in 1994 that the first MMA embolization was done. MMA embolization is generally considered to be a safe and effective treatment option for chronic subdural hematoma. However, there are some contraindications that are listed which may be unsuitable or unsafe for certain patients. And this study shows comparison with historical control patients treated only with surgery revealed MMA embolization outperformed surgical drainage, and the treatment failure rate during the 6-month follow-up in the embolization group was significantly lower than the conventional treatment group. However, evidence for the use of MMA embolization is lacking, with the majority of literature consisting of case report or small case series. As the interest for MMA embolization grows, more published studies have been documented, and there are ongoing clinical trials using different embolic agents to establish and further validate the effectiveness and safety of middle meningeal artery embolization. So this is an example of a proposed treatment algorithm for chronic subdural hematoma, and this may vary from per health institution. As we all know, MMA is a branch of the maxillary artery, which itself derived from the external carotid artery. The MMA, together with anterior meningeal artery and posterior meningeal artery, supplies the meninges, therefore supplies blood to the chronic subdural hematoma located in the mid-anterior to mid-posterior cerebral convexity. So this is a lateral DSA with injection of the distal ECA, demonstrating an important variant of ophthalmic artery origin from the frontal branch of the middle meningeal artery. This is a critical variant, and as the more distal central retinal artery represents a true end artery with no collateral supply, and inadvertent embolization during a distal IMA artery embolization with this variant results to permanent vision loss. So listed are the potential benefits and risks of MMA embolization. And in neurointervention, we used catheters, microcatheters, and their corresponding guide wires and microwires to access the MMA. We use different types of embolic agents to occlude the MMA depending on their availability as well as experience of the interventionist. So we proceed with some of the few cases of SIS. This patient presented with a headache and was noted to have subdural hematoma along the right cerebral convexity. The main meningeal branches are variably named for the territories they supply: the frontal, parietal, petroscomosal, or anterior and posterior branches. Further magnification angiogram shows cotton wool-like staining or blushing of the distal vasculature that you may see in chronic subdural hematoma. So the DSA shows glue injection flowing into the frontal and posterior branches of the right MMA, and glucose is evident post-embolization. These are the CT scans comparing subdural hematoma along the right cerebral convexity prior to embolization and 2 months after embolization, showing resolution. So the next case is a patient also presented with headache and noted to have subdural hematoma along the left cerebral convexity. Lateral DSA shows the tip of the microwire within the frontal branch of the left MMA. Microcatheter is pulled out as soon as glue backflow is observed to prevent inadvertent embolization and avoid the catheter being stuck within the vessel. So the safest policy is not to embolize from a position proximal or near the foramen spinosum to avoid embolization of the petrosal branch, which supplies the facial nerve, and avoid embolization of possible orbital anastomosis with the middle meningeal artery. So these are the CT scans comparing subdural hematoma along the left cerebral convexity 2 weeks after embolization, and 1 month after embolization. And the last case is a case of bilateral cerebral subdural hematoma and frontal parasagittal vascular malformation. So the left ICA-DSA frontal projection shows the AVM with main supply coming from the right ACA branches. And right ECA-DSA frontal and lateral projections shows arterial supply of the AVM coming from the MMA artery frontal branches. So on the contralateral side, you will see the left ICA-DSA lateral projection showing a branch of the left ophthalmic artery supplying the anterior division of the left MMA, which in turn partially supplies the AVM. Hence, we proceeded with selective embolization, first accessing the right ACA branches supplying the AVM. Post-glue embolization angiogram still shows significant AVM vascular supply. So we proceeded with selective embolization again of another branch of the right ACA to further decrease the vascular supply. Subsequently, the frontal terminal branch of the right MMA artery was also embolized. Since the parietal or posterior terminal branches of the right MMA was embolized as well, note the subtle cotton wool-like contrast staining prior to embolization. Since this case is a bilateral cerebral subdural hematoma, selective embolization of the left MMA frontal and parietal branches was also done. Note the cotton wool-like contrast appearance of the distal branches prior to embolization. So comparison of pre and post embolization of the right ACA anterior branches and bilateral MMA branches showed significant reduction of vascular supply to the AVM. This will be supplemented by gamma knife radiosurgery 1 month after embolization. So these are the CT scans comparing subdural hematoma along the bilateral cerebral convexities 1 week after embolization and 2 months after embolization, showing interval regression. As we see in the sample cases discussed with the pathophysiology of chronic subdural hematoma and studies supporting MMA embolization, this procedure is safe and effective as long as we know the etiology, aware of the vascular anatomy and possible variants, prepared and experienced with the right catheters and embolic agents for the procedure, optimistic of the outcomes, and willing to work as a multidisciplinary team. Thank you.